the structure of the program, as Janine said, is going to be a brief presentation. I will primarily focus on some of the updates from the American Society of Clinical Oncology meeting pertaining to ER positive or estrogen receptor positive disease. And then we'll open the forum up to questions that you can submit in your chat box. So let me just start sharing. So as we talked about, as I mentioned, we will talk about some of the studies. I will briefly review some of the options available for estrogen receptor positive breast cancer also, and I'm happy to answer any questions at the end of this talk. Just as a disclosure, I'm a speaker and consultant for Daiichi Sankyo and AstraZeneca, and we will be discussing some of those products today. So we will start off by discussing some of the advances in the early stage setting. So as many of you know, the goal of adjuvant systemic therapy, why you see a medical oncologist, is to eliminate or delay the appearance of micrometastatic disease. The strategies that we use in the clinic is anti-estrogen therapy for patients who have ER positive disease, chemotherapy for patients who have ER negative disease, HER2 amplified disease, and some patients with ER positive disease. HER2 directed therapy for patients who have HER2 amplified disease. And now with Keynote 522, immunotherapy with Keytruda for patients who have triple negative disease. Current strategies include individualizing treatment to the patient. And various factors come into play when we decide the right treatment for the right patient. So we have to factor in what are the risks, what are the benefits, what are the organ functions, age, comorbidities, and as you're aware, various prognostic and predictive factors, tests like Oncotype or mammoprint that you may have had or your providers may have discussed with you. So that really decides and tells us in the ER positive setting of how high risk that ER positive disease is and whether chemotherapy would be of benefit or not. So there have been significant changes in the recommendation for adjuvant anti-estrogen therapy in the last few years, including addition of ovarian suppression in younger patients and the incorporation of drugs like abemaciclib or Verzenio in the earlier stage setting, primarily higher risk setting with lymphopositive disease, higher tumor turnover with high Ki67, as well as now the use of targeted therapy with olaparib, which is a PARP inhibitor in patients who are BRCA1 and 2 positive who still have some residual disease. So this is just an update from the ASTRA study, which basically looked at women who were premenopausal and were taking tamoxifen. What is the benefit of adding ovarian function suppression? This is an 8-year follow-up. The 5-year follow-up was presented before. The SOFT trial was another trial that has been reported out, and it did show a benefit even at 8 to 12 years of adding ovarian suppression to tamoxifen. So this study had already shown some benefit, around a 3% disease-free survival benefit at 5 years. And at the American Society of Clinical Oncology meeting recently, what they did is they showed what was happening at 8 years when the patients were followed for a longer period of time. And the study design, just as, I'll keep this very brief, were premenopausal women aged less than 45. All women had estrogen receptor positive disease, stage 1 to stage 3, had been treated with definitive surgery, and patients had received chemotherapy. So this is a little higher risk population. Ovarian function was evaluated and patients were randomized 1-to-1 to receive tamoxifen or tamoxifen plus goserelin, which suppresses ovarian function. And the primary endpoint was disease-free survival. And so you can see the top curve is basically the disease-free survival, the patients who got ovarian suppression. And there was a 6% benefit in preventing the disease from coming back as time passes on. So at 8 years or 9 years, you can see that difference starts to increase. And this adds to the evidence that in the right patient, optimizing anti-estrogen therapy adds a lot when it comes to long-term survival. This adds to some of the studies we've seen from 5 years versus 10 years of tamoxifen. This adds to the SOFT and the TEX trials. So in the right setting, your providers will talk to you about anti-estrogen therapy, not only for 5 years, but also for 10 years. And the other strategy that is also done is not only using tamoxifen with ovarian suppression, but actually switching tamoxifen out to aromatase inhibitors. That has also shown to be of benefit in the right patient population. Just an overall survival hasn't shown a big difference right now, but that may change as time goes on. So moving to new data in the metastatic setting, as Janine mentioned, trastuzumab deruxtecan has now been approved in the HER2 low metastatic setting or unresectable setting. So I think one of the big things in the ER positive setting is now we see data not only from this drug, but another drug I will talk about shortly, which are antibody drug conjugates. And this is a new paradigm in the estrogen receptor positive disease, where you have an antibody that is directed to a receptor and it has a chemotherapy payload. The drug is stable in the blood and it is internalized into the cancer cells and then broken up. So the chemotherapy is delivered in a much more targeted fashion. So I would, the way I describe this to my patient, it is more of a tomahawk with using the receptor and delivering chemotherapy into the cancer cells. Trastuzumab deruxtecan will start with this. This drug is already approved in the HER2 amplified setting, and the Destiny Breast 04 was the first trial that compared it in the HER2 low setting. So what is HER2 low? So HER2 low is an unmet clinical need. When we test for HER2, we use immunohistochemistry or IHC. You may have seen the reports that said the HER2 is 0, 1 plus, 2 plus, or 3 plus. 3 plus is typically considered to be amplified, and HER2 2 plus is reflex to FISH to test for it. So your HER2 negative patients currently do not receive anti-HER2 directed therapy in the metastatic setting. HER2 low for this study was defined by IHC score of 1 plus or 2 plus, and FISH was negative. So technically they could not have received HER2 directed therapy in the metastatic setting unless this drug was available. So as I was mentioning about trastuzumab, this is an antibody drug conjugate. It has trastuzumab, which is basically Herceptin, bound to chemotherapy, and the drug is made available inside the tumor. It is internalized by the cancer cell and then broken down in the cancer cells, and the payload is delivered, or the chemotherapy is delivered. In heavily pretreated patients, you can, with HER2 low positive disease, median progression-free survival was 11.1 months and overall response rates were 37%. So Destiny Breast 04 was the first randomized phase 3 study of trastuzumab deruxtecan for HER2 low patients. Again, half these patients were estrogen receptor positive also. So this study is applicable to patients who have endocrine refractory hormone receptor positive disease. The primary endpoint was progression-free survival. The secondary endpoint was PSF. And just to clarify, the hormone receptor positive was around 480 patients. A lot of these patients were hormone receptor positive. This was compared to standard of care therapy, which could be capecitabine, gemcitabine, paclitaxel, Halaven, nab-paclitaxel, or Abraxane. And if you look at the progression-free survival, compared to whatever our current standard of care is, the median progression-free survival was 5.4 months. So 50% of patients would have disease response for greater than 5.4 months. Unfortunately, 50% will have disease response for less than 5.4 months. However, the same curves now change for trastuzumab deruxtecan for the median PFS of 10.1 months. So this is in the hormone receptor positive setting. In all patients, if you add the patients who are hormone receptor negative and HER2 low, PFS was 9.9 months and 5.1 months. So kind of similar efficacy that you can see across the whole patient population. So this definitely adds to a significant improvement in the PFS, and it adds to the drugs we can use and improving survival. So it really changes kind of how we are now approaching patients with recurrent disease or metastatic disease. We are not saving this drug only for HER2 amplified patients, but we are actually seeking out patients who are HER2 low, where we can actually offer them these drugs. The other antibody drug conjugate that was able to show some benefit in the estrogen receptor positive setting is sacituzumab. This drug is also called Trodelvy. It is already approved in the triple negative setting, and it targets a receptor called TROP2 and delivers chemotherapy into the cancer cells which are expressing TROP2. So this study, the TROPiCS-02 study, basically looked at using this drug in the estrogen receptor positive setting also. Patients were randomized 1-to-1 to receive Trodelvy versus physician choice, capecitabine, navalbine, eribulin, or gemcitabine. So these are all 4 drugs as standard of care. And there was progression-free survival benefit of a few months, a 34% reduction in the risk of disease progression. Overall survival benefit was, it's not mature, but further follow-up is anticipated. So both these antibody drug conjugates now make available more targeted therapy for patients who have ER positive disease, along with all the ER directed therapy that was available before already. So this is the last study we'll talk about. This is the MAINTAIN trial. In the hormone receptor positive setting, in the recurrent or metastatic setting, use of CDK4/6 inhibitors such as Ibrance, Kisqali, or Verzenio, along with anti-estrogen therapy, is now first-line FDA approved. The big question is what to do if someone has progressive disease. Can you continue the CDK4/6 inhibitor, or do you have to change that backbone? So this study really tried to see, can we add and get more benefit by switching the CDK4/6 inhibitor? And what they did is they randomized 120 patients to get who had already progressed on endocrine therapy and any CDK4/6 inhibitor to receive ribociclib or Kisqali plus switch endocrine therapy, or placebo plus switch endocrine therapy. And what they saw was there's definitely benefit of adding ribociclib when patients have not got it first line in the second line setting. And you can get another option for patients in controlling the disease for a longer period of time. So you got a hazard ratio of 0.57 in the progression-free survival. So MAINTAIN was the first randomized trial to show benefit of ribociclib and switch endocrine therapy after CDK4/6 inhibitor progression. One key part is palbociclib or Ibrance was the prior CDK4/6 inhibitor in 87% of patients. So one can say that patients who get Ibrance, they can get Kisqali in the second line, and that may be a viable choice. There was a 43% risk reduction of progression or death with ribociclib versus placebo, and higher PFS and PFS rate at 6 and 12 months. With this, I would like to finish my part of the presentation and open the forum up for any questions.
Thank you so much, Dr. Gupta. You really ran through a lot of recent research to help people understand some of these studies that were presented, particularly at ASCO just a couple months ago. We already have quite a few questions, so sure. I'm going to go ahead and get us started, and I'm going to kick us off with a question from someone who couldn't be with us tonight and emailed us in advance in the hopes we would address her question.
Sure.
So her question was, is 5 years still the recommended duration for hormonal therapy, or are researchers seeing better outcomes for longer periods, such as 7 years or 10 years?
Right. So this goes down to the ASTRA study I presented at the beginning of the talk. And that is actually yet another trial that says that extended duration anti-estrogen therapy in the right patient population would be of benefit. So in my practice, I tell patients already, if you have higher risk disease and you are someone who's only in their 30s or 40s, we really need to have a talk at the 5-year to see how you tolerated your anti-estrogen therapy first and foremost, and then talk about 10 years. But, tamoxifen, 10 years is better than 5 years. There was ATLAS study and the ATOM study. And then you have your MA17, which also showed that extending the aromatase inhibitors would be of benefit. Some clinicians also use breast cancer index to decide that. But as a rule, younger patients, patients who have lymph node positive disease, patients where you worry about what is the risk of late relapse, and patients who can handle their anti-estrogen therapy well, and they don't have problems like bone density. I think I won't say it's a blanket recommendation, but I think it is absolutely a discussion to have with your providers at the 5 years that, okay, am I a candidate for 10 years or not?
Thanks, Dr. Gupta. And just a couple of follow-ups to that. We have a couple of folks who are triple positive, so they also have HER2 positive disease,
Sure.
and are curious whether the amounts of time that you would take hormonal therapies would be different because of the HER2 status.
So I think that's a very good question. In general, Janine, what I would say is if anyone needed chemotherapy at the time of their diagnosis, they automatically, to me, are at a higher risk for later relapses also. So yes, that is a HER2, a triple positive patient because they got Herceptin. And again, the other part is I don't know if they had a pathological response or not, if they got neoadjuvant therapy. So there are various factors, but yes, a triple positive patient should definitely talk to their provider whether they are the right candidate or not.
Okay, thank you. And then another question sort of in follow-up to something that you mentioned is someone asking whether if you had an early stage hormone receptor positive breast cancer, would you expect if they had a recurrence that it would also be hormone receptor positive, or could it change
Yeah,
sometimes?
that's a very good question. I think the audience is asking. I like these questions because these are things that I actually talk in the I probably talked about both of these things already this morning with my patients. So these are like real world things, scenarios that happen. So yes, we always add that if someone had a recurrence, not a new cancer. A new cancer can have any receptors, but if someone had a recurrence, you always want to biopsy it because you can have change in the estrogen receptor. You can have change in the HER2 receptor. The HER2 can change maybe at least 10-15% of time. So there can be tumor heterogeneity also. The other thing, what we've realized is even in the metastatic setting, if someone has ER positive disease and it's been 6-7 years they've been on treatment, they can actually lose their estrogen receptor. So, I tell patients cancers are trying to evolve and trying to outsmart what we are trying to do to control them. So they will come out with resistant pathways or resistant mechanisms. So you always want to test if the biopsy is easy to do.
Thanks for answering that question.
Sure.
We have a number of questions about the breast cancer index test.
Right.
And what you think about that test, whether it's useful, whether after a period of time, whether your risk of distant recurrence could change after 5 years.
Right. So I think breast cancer index is a useful addition. It is in the NCCN guidelines now. I think, when I'm teaching, so I teach fellows also. When I'm teaching fellows, I think my only question about the breast cancer index is the long-term follow-up. And when I talk about long-term follow-up, I'm looking at 15 years and 20 years. Because hormone receptor positive disease, even if I tell a patient your risk of recurrence is 0.25%, a quarter of percent a year after 10 years, and someone is only 40, it adds up. So the late recurrences can happen. All of us know patients where they were diagnosed with breast cancer 20 years ago, and now they have a recurrence. So that is one of the things I think I tend not to use it too much. In all honesty, I tend to look at how their initial presentation was to make that decision. But a lot of clinicians, I have my partners who love the test. So every clinician is kind of trying to decide whether that's the right test that they would want to present to patients. I think the other part of breast cancer index is it does not factor in the tolerability. So I think, to me, continuing anti-estrogen therapy is really useful, but it needs to not impact quality of life. It should be something that the patient can tolerate and not feel like that it's a burden to them every day. If they feel like this is a defense shield and this is something that they want to continue and it is useful, it really can be a very good strategy.
Thanks for addressing that. And we are, I will ask some questions about side effects during this program. We have a
Sure.
number of these
Absolutely.
questions.
Yeah.
Our next question is from someone who's asking if the percentage of estrogen or progesterone matters. If it's a lower percentage,
Yeah.
is it related to fewer, less chance of a recurrence, or to the type of treatment you would get?
Right. So another very good question. When we look at the staining, estrogen receptor staining, it can vary from 1% to 100%. And I think and there can be tumor heterogeneity. Some areas may be slightly high and some areas may be slightly low. So this can create a little bit of discussion when it comes to deciding therapy of what, do you want chemotherapy? Do you not want chemotherapy? As a general rule, patients who have lower estrogen receptor or lower progesterone receptor tend to have higher molecular risk tests results. So if someone is progesterone receptor negative and estrogen receptor is 60% compared to 100%, their oncotype may be higher. So you don't really use the receptors just by themselves to decide chemotherapy or not. That is, like, in this day and age, you will use tests like oncotype, you will use tests like mammoprint to make that decision. I recently had someone whose estrogen receptor was 15% and progesterone receptor was 15%. And I was debating, should I treat her like a triple negative? Because sometimes these will behave like triple negative, or should I treat them like estrogen receptor positive disease? So we got a mammoprint, which actually showed that the molecular subtype was actually luminal. It wasn't basal type. So that kind of told me that, okay, I can treat her like an ER positive disease. The other part of your question was, if it is less estrogen receptor, do you need less anti-estrogen therapy? So the answer, the by the book answer is, if your estrogen receptor is positive, it is always worthwhile trying anti-estrogen therapy and see if you can tolerate it, even if it is 10%, because there can be some heterogeneity when it comes to staining. Patients who have, sometimes I've had patients where one institution reported it as 40%, the other institution reported it as 5%. So these stains, when the receptor expression can be low, the staining can be different. So as a general rule, if you have estrogen receptor positive disease, even if it is 10%, you really want to have someone on anti-estrogen therapy. The duration, I think we spoke about it. The percentage doesn't really decide the duration. The percentage tells us to, okay, what kind of molecular test we would order. It decides whether you should even get anti-estrogen therapy or not. So I hope that was kind of, helpful in answering those questions.
Thank you. I think one of the themes I'm getting from a lot of your answers is there's so many conversations to be had with your doctor, and to kind of explore what your doctor thinks about the tests and how it works with your quality of life over time.
Right. I think one of the big things I would say is, in 2022, we are very fortunate enough that we just do not have to look at the estrogen receptor and the progesterone receptor in the early stage setting to make treatment decisions. So please make sure, if you have a cancer that is more than 5 millimeter in size, you're getting that molecular test done. I think that is one thing to take away from my talk. If someone has early stage disease, which is estrogen receptor positive, getting an oncotype, a mammoprint, or any molecular testing is something that is standard of care. I think that is like very, very important, because I have a patient who went to a really big institution down south. I will not take the name, and the oncotype was not done for a 1 centimeter cancer because she was 70, but she's a really good 70. And we did the oncotype and it turned out high risk. But, so I think that is something that should the molecular testing, or the next level of testing to get an insight of the DNA biology of the disease, more than just the estrogen progesterone receptor, is super important when deciding the chemotherapy discussion.
Thank you very much. I really appreciate that answer. So I'm going to pivot and ask a few questions from our attendees who are living with metastatic breast cancer. And I want to start with this first one. I have metastatic breast cancer and I'm on Ibrance. What can I do once it stops working? I've been on Ibrance for 6 years and my doctor says there's nothing else available.
Yeah, I think did they say which anti-estrogen therapy they're on with Ibrance? So typically, Ibrance or palbociclib is used in combination with an anti-estrogen therapy, either the injection called Faslodex or one of the aromatase inhibitors. And I'm so glad that this person is doing well for 6 years on Ibrance. So it's really good to know that she's doing so well on it. But I think this is she really has not been, she's basically scratched the tip of the iceberg. That's kind of the term I would use, with all the treatments that are available to us. Things like, we looked at the maintain study, now there's data for using Kisqali after palbociclib. But there is testing for things like PIK3 mutation testing, things like Afinitor, so there are like so many anti-estrogen therapies available. And then you kind of start with chemotherapy. So, you definitely can avoid the use of chemotherapy in this setting for many, many, many years. And I think one of the chemotherapies that is used quite a lot in the metastatic estrogen receptor positive disease is Xeloda or capecitabine, because it maintains quality of life and patients don't have to come to the office for an IV treatment. So I've had patients like decades on, actually almost 9 years on just Xeloda in the metastatic setting. So, and now with Enhertu, that may be another great option. So the only thing I'll tell this person is she has a lot of options. There's a lot, she has a lot of life in front of her.
Thank you. So it's interesting. The next question is from someone who is asking about what to do after you have progression on Xeloda and you have had a CDK4/6 inhibitor. Can you take a different CDK4/6 inhibitor? Do you need to move to a different chemotherapy treatment? What is typically recommended?
Right. So capecitabine or Xeloda is a very good drug. It's been around for a few decades now. It's used in colon cancer and breast cancer. Again, I don't know the details of this person, but what I would say is, right, even based on what we talked about today with Destiny Breast 04, I would look at her HER2 status and see if she's HER2 low or like 1+ or 2+ FISH negative, or even repeat the HER2 testing. Maybe the HER2 is amplified now. So Enhertu may be a very good option for this particular person. So that's one part of it, just looking at the data from the Destiny Breast 04 study. I think the other drug is also a good option. Trodelvy is a good option. But going back to the CDK4 question, I think the maintain study does give us some insight for patients who have got palbociclib. I think ribociclib may be a viable option. The only comment I would say is the study was only 120 patients, so it's not a 600 patient study. The other thing to also check for is PIK3 mutation testing. PIK3 is a very good drug. And if that mutation is not there, then Afinitor is a very good drug. So, you kind of use that path to do. And the last thing, just before, IV chemotherapies, I'm not going into a deep dive with this question, but in the right patient setting, there is an oral combination of cyclophosphamide and methotrexate, the metronomic low dose, which actually is very well tolerated and can have effectiveness in a lot of patients.
Thank you. Thanks for answering that. Another attendee is asking about Verzenio.
Yeah.
And they're curious about why the commercial says that you take it every day, and what is the difference there between that and other CDK4/6 inhibitors?
Right. So, if you look at Ibrance, which is the other more marketed thing, the toxicities of neutropenia do not let you take it every day. You have to give a break. I think that's the thing. And again, the pharmacogenomics of both these drugs are very different. Verzenio is actually twice a day. Palbociclib is once a day. So, it depends on the half-life. It depends on how they bind to the receptor. So it really, this is like biology 101. I would have to show them the phase 1 trial of the pharmacogenome, actually phase 0 trials, to have this discussion. But the one thing I can tell them is this is the way the drug is FDA approved. So Verzenio is twice a day, 50 milligrams, 100 milligrams, 150 milligrams, and in some patients, 200 milligrams. Palbociclib is 75, 100, 125 daily, 3 weeks on, 1 week off, with careful monitoring for toxicities.
Thank you. It's a really, it's confusing.
It's very,
a lot of information.
Yeah.
So speaking of confusion, there's quite a few questions in our feed wanting to get a little bit more understanding about Enhertu and HER2 low in hormone receptor positive metastatic breast cancer. So could you talk a little bit more about how HER2 low is defined?
So HER2 low, I did rush through my slides. I wanted to make sure we had time for questions because that can go down. So, but if you look at, I would encourage people to actually go to the Enhertu website. They have a very good explanation of what it is. But just to summarize, HER2 is tested by immunohistochemistry. And the second method to test for HER2 status is by FISH, or fluorescent in situ hybridization. So when you look at IHC, it is reported out as 0, 1+, 2+, or 3+. So 3+ is already amplified. The 2+ is then sent off for FISH, and it can be reported as amplified or non-amplified. So now there are there are a lot of patients who are hormone receptor status positive who may be HER2 1+, or they may be 2+ and FISH negative. So your HER2 low is basically hormone receptor, HER2 low is basically HER2 1+ by immunohistochemistry, or 2+ by immunohistochemistry and negative by FISH. I was explaining it to my nurse practitioner. Basically, Enhertu is an option for pretty much everyone now, unless they're HER2 0. That's the simplest way to clarify that. That instead of being safe for the 15 to 20% of patients who are HER2 amplified, meaning 3+ by IHC or FISH amplified when they're 2+, now it opens up to almost 60% of patients who have metastatic disease. So this definitely is a big game changer. Does that kind of make sense?
Definitely. Thank you for explaining that. And another question that's coming through a bit, just to be clear, it was approved in the metastatic setting only. It's not currently approved in the early stage setting.
No. So all of this discussion is in the metastatic setting. So that is absolutely correct. They have ongoing studies in the earlier stage setting, post chemotherapy, residual disease, but this is all pertinent to the metastatic setting. Trastuzumab by itself was studied in the HER2 low setting. NSABP B47 was a study we participated in, where we actually treated patients with Herceptin for a year when they were HER2 low, did not show a benefit. So some of it is also drug related. And HER2 is not just a monoclonal antibody, is an antibody drug conjugate. So I think the big change this year for ER positive diseases that you have 2 new antibody drug conjugates that are now potentially an option, which were not an option 3 months ago.
Thank you. And then one person is asking whether Enhertu can be taken with other ER targeting agents like Ibrance or anastrozole.
Right. So patients in the study had already been treated with, they were endocrine refractory. So there's no reason to take Enhertu if you have anti-estrogen therapy options or if you have CDK4 inhibitor options. I would not jump to Enhertu unless you've already been treated with Verzenio and Faslodex and aromatase inhibitors. I would work on the pills first because Enhertu is IV and it's every 3 weeks. So I think the study included patients who had already progressed on the endocrine therapy.
Thank you.
And then you do not also take it. It is a single agent drug. You do not combine it with Herceptin. You do not combine it with Perjeta. You do not combine it with chemotherapy. It is a single agent drug because it already has an antibody and it already has chemotherapy.
Thank you. So someone is asking, would you do a tumor biomarker test, a molecular test, if someone has metastatic breast cancer?
So we already, and that's a good question. Doing a next generation sequencing panel, tests like Foundation Medicine, tests like Caris, tests like Guardian, is standard of care in all diseases now, where you have metastatic disease, just to find any kind of other abnormalities. The good thing about breast cancer is that we already have so many targeted agents, including these 2, which will potentially, one is already FDA approved, the other may get approved in the ER positive setting. The big important part when it comes to looking for genomic abnormalities in the metastatic setting is really the PIK3 mutation as things stand right now, because it decides if someone is a candidate for PIK3 or not, which is a PIK3 inhibitor. So that's the important utility. So the simple answer to that question is yes, it should be done. If it hasn't been done, it absolutely should be done. It doesn't need to be done on the tumor. One can do a liquid biopsy also, which is basically a blood test, and the result comes back in 7 to 10 days, and which can tell you whether you're a candidate for PIK3 or not in the metastatic setting.
Great, thank you. So I'm going to move now to some questions about side effects. I am hoping to get to more of these other questions toward the end of our program. There's a number of questions from people about how to maintain their bone health while they're taking aromatase inhibitors. Could you speak to that question?
So, things I speak to patients about is, number one, you always want to know what your baseline bone density is. I cannot tell you how many times I'll see patients who are postmenopausal, they're 60, they've been diagnosed with breast cancer. And my first question to them is, have you ever had a bone density? And the answer is, what is a bone density? And mind you, I live on, my practice in mainline Philadelphia. So this is not like I'm in the middle of nowhere. But that's one thing, all postmenopausal women should have a baseline bone density, because, what we don't know is how much is the bone density loss to begin with. Family history does play in, what kind of physically active person you are does play in. Maintaining bone health during anti-estrogen therapy is very important. So getting a baseline bone density is important. We in our practice do recommend taking some calcium. We monitor vitamin D levels. There are multiple weight-bearing exercises. That's another important part about maintaining bone density. And then we get into pharmacological therapy. Sometimes we'll send our patients to rheumatologists. Sometimes I will manage those patients myself. There are drugs, things like Prolia, things like Reclast. So there are agents that are FDA approved in this setting to maintain bone density. And I think monitoring the bone density on these drugs, the standard of care is to monitor it every 2 years. So you want to monitor it. I've had patients who have mild osteopenia and they really did not want to go any pharmacological treatment, and that's fine. We talked about weight-bearing exercises, maintaining vitamin D, trying to get that level up to like 50 or 60, and then they were able to preserve their bone density. So it's very, very doable. It's very, very manageable. It just requires attention to detail. That is what I would say.
And there's a couple of people who are concerned about taking these medications and the risk for osteonecrosis of the jaw. Can you explain what that is and who might be at most risk for it?
Right. So I've had patients with concerns. I think one of the things to educate patients is it's a side effect where you have non-healing ulcers or non-healing bone areas in the jaw. And typically it is seen more in patients who already have a poor, have some dental issues, they have implants or they need gum surgery. I think, I can just talk to my experience when it comes to osteonecrosis. It is a condition that is very well recognized. And, we try to make sure that all our patients, it is actually imperative in my practice that before we start any bone modifying agents, patients are evaluated by their dentist. We want to make sure they do not need any major dental work done. The other thing to also remember is, I hear a lot of concerns about Prolia and ONJ. I think one of the important things to remember is when you talk about the package insert, it actually talks about denosumab, which is Prolia and Xgeva. So Xgeva is the same molecule. The dose is double Prolia and it's given every month. So in a given year, the exposure is 12 times of Prolia. So yes, I have seen ONJ on Xgeva. I personally haven't had a single patient on Prolia having ONJ because the dose is so low relative to how we use Xgeva. Same thing with Reclast. We use it once a year, but in patients who have disease in the bone, the drug is used more frequently. So I think, if you talk to a medical oncologist, we see ONJ really more in patients who are getting these drugs much more frequently than someone who's getting it for bone health prophylactically. So that's kind of the clinical experience I can share with the audience.
Thank you. The next question is about how hormone suppressors affect dryness and pain during sexual intercourse and sexual intimacy. What can be done about it, especially in this setting where people have had hormone receptor positive breast cancer?
Right. So I think, when I was in fellowship, and I'm dating myself now, like 13, 14 years ago, we had a lot of concern about using intravaginal estrogen, but I think that has really dissipated because the systemic absorption of intravaginal estrogen is really minimal. So I think, meeting with a gynecologist who takes care of patients who have breast cancer, I think is a first step, if possible, in your community, because that's one of the biggest challenges I've seen. I've had gynecologists who are very comfortable in co-managing my patients with me and being very comfortable in, looking at other alternatives, not only intravaginal estrogen, but, sunflower oil or other things. But I think to me, this is one of the big quality of life issues that absolutely comes up, and we talk about it before we start. But I think having a good gynecology who can co-manage the patient with you is very important. Mainline Health actually has a specialist who specializes in sexual disorders for patients who are undergoing cancer therapy. So that is a very helpful resource to me also, to help me kind of help my patients. But I think, if you hear any provider saying that, they will not give intravaginal estrogen, which can be very helpful to patients, that's little like dated, I would say, at this point.
Definitely a point of controversy for a lot of people, and
exactly
an area of confusion.
Exactly. So I think that's one thing I tell my patients is, obviously you don't want to use it excessively, but as little as possible to maintain a good quality of life. It is not like a big no. It goes down to, I had my lymph nodes taken out and I can't have my blood pressure taken anymore. It falls in that category.
Thank you. Thanks for explaining that. Someone is asking, this is sort of a clarifying question. Can you explain what type of drugs aromatase inhibitors are? Some of my doctors call it chemotherapy. Is it chemotherapy? Why is that term used in regard to these drugs?
Right. So no, they are not technically chemotherapy. They are aromatase inhibitors. So aromatase is an enzyme that is involved in the production of estrogen in the postmenopausal setting from the adrenals and the fat cells of the body. So these drugs basically inhibit that production of the minimum amount of estrogen that can still cause breast cancer growth. I think it depends on the physicians. I think the other area of confusion is some practices have participated in the oncology care model, and Medicare actually classified them as chemotherapy for 5 years. So I've had patients who have kind of brought up the same question to me, that I got a letter from Medicare saying that I'm on chemotherapy, but you told me it's not chemotherapy. So I've heard that question a few times before, but no, they're not chemotherapy. Technically, I like to not call them hormonal therapies because they are not hormone replacement. I like to use the term anti-estrogen therapy because that's what they're doing.
Thank you. The next question is about ways to minimize side effects in general and improve quality of life while taking aromatase inhibitors. Is there any effort to decrease the dosages or the strength of these medications from the highest tolerable dose to the lowest effective dose?
Right. And I think that's a very good question. This has come up multiple times. Unfortunately, the way these drugs were studied in the trials, when they were studied, they were dosed in a standard fashion. So anastrozole, for example, was dosed at 1 milligram per day. Exemestane or aromasin was 25 milligrams per day. Femara or letrozole was 2.5 milligrams a day. And tamoxifen is 20 milligrams a day. But there has been effort. I would say this is one of those unmet needs, but I have seen some improvement. So I'll give you an example. When it comes to aromatase inhibitors, what I would say is that there was some recent data where they actually tested for estrogen level and suppression based on exemestane once a week, 3 times a week, and daily. And what they saw was that the suppression was equivalent if you do it 3 times a week versus daily. So this is, I know I would not recommend this to the general audience today that, oh, please start taking your AIs 3 times a week. That's not what I'm trying to say. But I think if these drugs are causing quality of life issue, which then impacts compliance, I think doing something, at least we have some biological basis that at least doing it 3 times a week or 4 times a week is better than not doing it whatsoever. So yes, there is emphasis on trying to figure out, if we can get with lesser dose. And I think we are seeing some effort coming out of that.
Great, thank you. Are there any supplements that people should avoid while they're taking aromatase inhibitors?
This is a loaded question. So my disclaimer is I'm not a naturopath. When I have a supplement question, I work with very good naturopathic doctors, NDs, and they really are kind of my complementary medicine support person to answer that question. So that's kind of what the good part about aromatase inhibitors are there are not a lot of drug interactions, but the problem with supplements is there are so many of them that I cannot tell you that there are 15,000. There are more supplements than FDA approved drugs. And every supplement says the efficacy has not been approved by evaluated by the FDA. So I really can't speak to what a supplement contains to give that blanket recommendation. So I would get input from a naturopathic physician if you can get access to one.
And Dr. Gupta, you would want to know, would you want your
Yes.
patient to tell you about supplements that they were taking?
Yes. So whenever I have, when people are like, oh, I want to take a multivitamin, that's fine. But then when they get into supplements that I have not seen, I have not heard about, I always get the input from the naturopathic physician.
Great, thank you. So one more question on side effects. One of our attendees hasn't started their anti-estrogen therapy yet because they're at the beginning of early stage treatment and is very worried about feeling like I'm going through menopause again because she's already been through natural menopause. Sure. Is that something she could experience? Are there ways to avoid the common side effects that one gets during menopause?
So I think that's a very kind of important concern. And, if this was someone I was seeing in the office, I would kind of go down to how, what problems they had when they went through menopause. Sometimes I have actually started my patients on 3 times a week for a month to assess their tolerability and make sure that they tolerate their treatment well before we then increase it to a daily dosing. So I think some of it is the art of medicine and the science of medicine. The science has started at full dose, but sometimes I will start slow and then slowly build up based on their tolerability.
Great, thank you. So I'm going to move to just a mix of different questions from our attendees with early stage and metastatic breast cancer. So one of the questions that I'm seeing repeatedly here is for you to talk a little bit about the Ki-67 test, right, how it's used in this setting. Is it critical? What does it mean?
So Ki-67 is basically a proliferation marker. It looks at, if you look at 100 cells, it looks at how many cells are actively dividing. It can be a very useful test in figuring out what is the underlying biology of the disease. It is one of the tests that is actually looked at when the Oncotype test is done. It is one of those 16 cancer-related markers that is tested and is built into the algorithm of Oncotype also. As a general rule, the higher the Ki-67, the more faster growing cancer it would be. So I saw someone who had triple negative disease, their Ki-67 is 90%. Higher oncotypes typically will have a higher Ki-67. So I think getting that information is important. In mainline health, in our health system, around 2 years ago, we incorporated Ki-67 along with our ER, PR, and HER2. So, if you have all of those 4 markers, and if you are in a setting where you don't have easy access to oncotype or genomic testing, like some of the countries outside the US, they actually use IHC4 panel in making that decision. So any Ki-67, when you're getting to more than 20%, you get into a range where typically your oncotypes and your mammal prints would be high. But what I would say is we use Ki-67 to tell the patients, okay, your oncotypes are probably going to be low or probably going to be high, but we still get our oncotypes and we still get our mammo prints because we have access to that. Once in a blue moon, I will have patients where the oncotype or the mammo prints do not work because of quality control issues. And I have been able to decide chemotherapy decisions based on Ki-67. So think about it as an adjunct of getting information about your disease. If you can get a genomic test, that's even better than a Ki-67, that would probably be better. But getting a Ki-67 does give you an input about the disease biology.
And Dr. Gupta, can you explain why is it better to get the genomic test rather than?
Because the genomic test is not just looking at one factor. Mammo print is looking at 70 genes. Oncotype is looking at 16 genes and 5 control genes. So you are basically getting a much more broader input with respect to different genes, different survival genes, different proliferation genes that the cancer may be using to grow. So the better you get a better insight than just getting insight from just from Ki-67. It's better than nothing, but getting your molecular test, I think, as I said, one of the important themes of today's talk in the early stage setting is if your tumor is more than 5 millimeter, you need a molecular test. That is super important.
Thank you. And there actually is someone who was asking, how do you compare oncotype and mammoprint, and should you be choosing among these tests? How do you know which is the right test to get?
Right. I think that's a really good question. Some of it I would tell you is practice patterns of what the person has used forever. Oncotype has been around for a little longer period of time, at least, for the Canadian audience, it has been around more. It has been around a lot more in the US. It has been used more in the US. Mammoprint used to be done only on fresh frozen tissues, and now it can be done in paraffin embedded blocks also. I use both the tests. I tend to use more oncotype just because our surgeons are much more comfortable ordering it. And this is something that we've used for 10 years. I think mammoprint is a really good test in figuring out the disease biology, especially as I gave the example earlier in this talk about, if someone is basal type or luminal type, like triple negative, sometimes you can find different phenotypes in mammoprint. I don't think these tests have been compared head to head. And it could be a 2-hour discussion about who should get what tests. So I don't think I can get into too many details because there are a lot of nuances, lymph node positive disease, premenopausal, postmenopausal. So there are like multiple variables and multiple studies that are out there. I think the discussion with your provider should be, am I getting a test? And please explain the results to me. That's all. That's really the 2 questions to ask.
Great, thank you. Someone is asking whether liquid biopsies are useful in locally advanced non-metastatic cancers.
So typically not. In the breast cancer setting, and even in other diseases, when you have locally advanced disease, you basically have disease that is in the lymph node. I hope they're talking about resectable locally advanced disease, not unresectable, just to clarify.
They didn't say, but I would think just from the way the question was asked that it could be removed with surgery.
Right. If it can be removed with surgery, there's no data for using liquid biopsy. The yield is much less and it doesn't really change your management. The important thing about breast cancer is there are a lot of markers we can get on tissue. So we don't really need to jump to liquid biopsy in this setting.
Thank you. So our next question is about the CDK inhibitors. This is about Ibrance and the low white blood cell count and the different dosages available. Is a lower dose less effective? Is the higher dose better? Do they all work the same? But so why are there 3?
Right. So there have been retrospective analysis which have shown that dose reductions does not change survival. The standard dose is 125, but based on the prior history, if you got chemotherapy before, if you did not get chemotherapy before, how sensitive your white cells are, I think it's a drug that you can use at 75 also. So I would not get concerned whether if you needed a dose reduction, you lose efficacy. That used to be my concern till I saw the data a few years ago that when you look at patients who had dose reduction, the survival did not matter with respect to changing, right?
Thank you. We have a question from someone who's watching us on Facebook. What is available for people who have an ESR1 mutation and who have had progression after a CDK inhibitor?
Okay, so that's a good question. I think, we talk about Faslodex in patients who have ESR1 mutation. There are a lot of companies that are trying to target the ESR1 mutation, with oral selective estrogen receptor degraders. So that is an area of active investigation. But, my second question to them is that, do they have a PIK3 mutation? Because if they don't, then Afinitor or everolimus is a good option. If they do, then Piqray would be a good option. So there are options definitely out there. So Faslodex would be one. A clinical trial, if they can get access to it, of an agent that is targeting the ESR1 mutation, would be another good option.
Thank you. I'm going to ask another Facebook question. I think it's an important one. How do I find out what my estrogen receptor and progesterone receptor percentage positivity are? Where do I look?
Right. So it's in the pathology report. It should be in the pathology report. So, if you have access to your health portal, or if you don't, ask your healthcare provider about your pathology report. It is always in the official pathology report. So we always give our patients, in our health system, our patients have instant access to everything we can look at. Like if a scan is done, as soon as I see it, my patients see it. It is instant access. And same thing about pathology labs. So it is there in the pathology report. That is exactly where I go to look at it also. It doesn't come, like if someone has a biopsy, the report may be out saying that if this is cancer diagnosis, it will say cancer, and then the receptors follow a day later. And again, it depends on the institution. There are institutions where they have a 24-hour policy for pathology reports and a 48-hour policy for receptors. So that's kind of the standard that our institution follows. There are some other private labs which could lag behind by 3 or 4 days.
And if they're really not sure how to figure this out, who should they ask? How can they get that information?
So I think talking to your physician is one. Talking to your nurse navigator, they are very helpful. So, they have access to the same information your physicians have access to. So those are two, if you're going for chemotherapy, your chemotherapy nurse, all your providers, be it the nurse, everyone has access to those records. These are not esoteric records when it comes to someone who's taking care of patients who have cancer. These are things that are like, this is one of those things you have to cross your T's and you have to dot your I's. Knowing your receptor status is super important to me. I cannot make any decisions till I get your receptor status.
Great, thank you. So my next question is from an attendee who is young and premenopausal and wants to know if they decide to pause their anti-estrogen treatments for a period of time to try to conceive.
Yeah.
Is it dangerous? Is it dangerous to do IVF? Does it increase risk for recurrence?
So that's a very good question. It depends. So I think one of the things is there have been studies that have actually looked at this question. I think a few years ago at the American Society of Clinical Oncology, some data was presented. So you want to at least do anti-estrogen therapy for at least bare minimum 2 years. And then you can take a break. So if this person is premenopausal, I think they are on tamoxifen. I'm assuming they're on tamoxifen if they're thinking about getting pregnant. So I've told patients, I've counseled my patients, try to do at least bare minimum 2 years of anti-estrogen therapy, and then you take a break, and then kind of, get back on the anti-estrogen therapy. I think one of the big things is there are so many nuances when it comes to this question that checking with your provider is going to be super important. There are so many different protocols that the IVF people use that it's very difficult to give a blanket recommendation when it comes to what are they using. Are they using an aromatase inhibitor to induce, and then I think it also actually goes down to actually, if possible, having IVF before getting chemotherapy. So I think fertility preservation is very important kind of prior to getting treatment, if that is something to think about.
Thank you. And another attendee is asking, She is also premenopausal. And if you start tamoxifen and then go through menopause after a year or two of taking that medication, should you switch to an aromatase inhibitor or continue with tamoxifen?
No, so I think, again, a very good question. That definitely is of benefit. There have been studies that have shown the big I-98 study did show a benefit of aromatase inhibitor and the ATAC trial also. So there are two studies that have shown benefit of aromatase inhibitors over tamoxifen in patients who can tolerate it. So what I tell my patients is you absolutely, you've gone through menopause, you did okay on tamoxifen, this is your good backup drug, let's try the aromatase inhibitors. You don't like one, you switch to another one. You don't like the second one, you try the third one. And if you don't tolerate them, then you go back to tamoxifen because you knew how you felt on tamoxifen. So it is very important to kind of try all the four drugs eventually.
Thank you. Can you speak to, we have a number of folks here who have lobular ER positive, PR positive disease. Is there any research that shows differences in outcomes with lobular or differences in treatment? What do you see on the horizon for people coping with lobular breast cancer?
So I think, the key differentiating part of lobular cells is they tend not to form cohesive masses. They tend to be a little bit more infiltrative. They don't stick to each other. Unfortunately, this does not change our treatment decisions because the treatment decisions are really guided by the receptors more than anything else. There are a lot of people from an academic perspective who are actually trying to exploit the characteristics of these cells to come up with new drugs, but nothing that is FDA approved right now. So as things stand right now, your hormone receptor status really decides the treatment paradigm in the early stage setting.
Thank you for speaking to that. A couple of people are asking about what kind of follow-up they should do after their initial active treatment, especially with the late recurrence risk. How does it change over time in terms of monitoring?
Right. So I think that's a good question. What I tell my patients is that I will basically see them for the rest of their life. So I do, I see my patients at least once a year. I think education is important. I think educating primary care doctors is important. A lot of centers have survivorship clinics that, women are transitioned to. I think being cognizant about things like new back pain, anything that is persistent progressive is problematic. So those are kind of the acronyms I use in clinic when I'm teaching fellows. Is the 3 Ps. If you have a problem which is persistent, and it is progressive, there is something that needs to be done. There is in this kind of breast cancer setting, there's no role for routine scans. Multiple studies have shown that does not change survival. So it actually, to a great extent, is following up with your provider at least once a year or twice a year, even if you're 5 years out. Sometimes some providers will do blood work to monitor that, liver function test or bone enzyme test. Some people like to check tumor markers. Some people don't like to check tumor markers. That's another Pandora's box we can get into. But I think being cognizant of what your normal body is very important, and regular medical follow-up is very important. The other thing I would like to say is, some of the drugs, especially aromatase inhibitors, can have some cardiovascular toxicities long-term when we talk about doing them 10 years. So we talked about bone health. We did not talk about cholesterol monitoring and cardiovascular risk screening. So that's one thing, we have a cardio-oncology risk program. Once I'm past 5 years, family history, those things I will try to get my patient in to kind of see a cardiologist at some point, just from a calcium screening perspective, or maintaining their health from an other body system perspective also.
Thank you for addressing that. Our next question is for someone who's saying bone mets are the most common place for ER positive disease to progress. Is it possible for progression to skip to other organs such as the liver, lungs, or brain? Or is it specific to the patient, or is it specific to hormone receptor positive status?
So I think this is where statistics come into play. Statistically speaking, bone mets are one of the most common presentation for recurrence in the ER positive disease. And yes, they can be the only site of recurrence. However, it also depends on the, what is the time lag of diagnosis. Like if someone had back pain and then they were going to a chiropractor, but no one did a scan, and then by this time they also had some disease in the liver or the lung, that's the impossible part to predict. So we try not to make an assumption, even though we know we will, if someone has recurrence being seen on an imaging study, I will always get a biopsy to check those receptors. And yes, you can have patients, I've had patients where they've had recurrence only in their distant lymph nodes without going to the bone, only in the lung without going to the bone. So, this is where statistically speaking, yes, bones should be the most common, but a person is not a statistic. A person is a person.
Thank you. So for our last question, someone is asking, when you look over the next 10 to 20 years, what are the approaches that you think are most exciting in hormone receptor positive breast cancer?
So we briefly mentioned it I briefly mentioned it in my talk, the use of abemaciclib or Verzenio in the earlier stages of setting. So I think that the Monarchy trial has really, that is the first FDA approved agent in the last 20 years in the earlier stage setting. And you can see as time is going on, you're seeing pretty significant changes in the survival curves. I think ER positive disease is not a single entity. It is a very heterogeneous disease. So you have patients who are very low risk and you have patients who are high risk. Identifying it, customizing the anti-estrogen therapy, is it going to be tamoxifen? Is it going to be aromatase inhibitors? Does someone need ovarian suppression? Does someone not need ovarian suppression? What is the treatment duration? Is it 5 years? Is it 10 years? How to maintain compliance by managing side effects. So I think if you look at the horizon, I see better outcomes, less relapses because our drugs are getting better. We have better understanding. We try to avoid over-treating patients and we try to judiciously treat the higher risk patients. So I think overall, I think our survival is going to be better. Our disease control is going to be better. Our relapse rates are going to be lower. And understanding how to manage side effects and improving quality of life, how to integrate complementary therapies. Those are all important things that I think I can see, even in the last 10 years since I've been doing this, there's a big change in how we are seeing our patients do well and live better.